Hey guys, could I run a case by you? A situation to talk about here. So I want to talk to you about this lady who I saw in my primary care clinic. She's 35 years old. She had just come in to me to establish care. She really doesn't engage in healthcare at all otherwise. But she had been in the emergency department a week before, complaining of some abdominal pain and vaginal discharge. They sort of presumptively treated her for gonorrhea and chlamydia, having not done any testing. And they gave her a dose for expedited partner therapy as well. And then they did a rapid HIV test, which we do in a lot of our emergency departments now, and that rapid test was negative. And she was referred to sort of, emergency department discharge follow-up to come see me. So when I started diving into her history a little bit, she didn't have much medical or surgical history at all, but she was engaging in a lot of risk. So I started diving, into her risk behaviors a little bit. So it turns out that she has been injecting heroin on almost a daily basis, on and off, for about 10 years. She is sometimes injected by her partner, as women often are, and she's, in that case, second on the needle. She tries to not share needles and syringes, but sometimes she does share preparation equipment with him. So cookers, cotton, things like that. And then when I started talking to her about her sexual behavior, she talked about that she does sometimes exchange sex for drugs, and she doesn't always use condoms with her kind of commercial partners, but she does have this boyfriend. She never uses condoms with him. So what do I do with her? To me, she clearly screams HIV risk, but how would you all approach sort of addressing that risk with her?
Yeah, she certainly has a lot of risk factors here.
Mm-hmm.
I think the fact that she exchanges sex for drugs, and sometimes and even if that weren't the case, just the IV drug use alone, we know that HIV PrEP is effective in preventing HIV transmission in people who inject drugs. So it's sometimes we're so focused on the sexual risk alone that we forget that it also is effective for prevention in that population. So I think this is somebody who would certainly be a great candidate for PrEP. So I at this point I would then do the initial workup to make sure that I would discuss PrEP with her, and I would then get the workup going so that I can initiate PrEP as soon as possible in somebody like her.
Mm-hmm. This is a really hard one. This is really challenging because there's so much chaos in this woman's life, and I think while on paper we can say, well, she needs this, this, and this, and PrEP's on that list. There is a long list, and I do worry about her living situation. Does she have a stable place to stay? Is she safe? Food insecurity. There may be a whole lot of other things on her own list of what she would like to have dealt with or that are important to her, rather than, whoa, here's a pill that can protect you, and here's a study that shows that it can protect you against getting HIV. She may be, I haven't acquired HIV now, up until this point, am I really going to get it moving forward, and do I really have to take a pill, and how am I going to do that with all the other things? So I think it's a great idea. I do worry that there's a lot going on here, and there may unfortunately be some other things that have to be dealt with first. I just would be worried that we would do it, and the worst situation we really have to watch out for is someone who takes PrEP, then stops taking PrEP, gets infected, right, and then starts back on PrEP. And the reason is that the TDF-FTC is just insufficient alone to treat HIV. It's great at protecting people from acquiring HIV, but alone is substandard, and you would develop resistance. And we've seen that happen in a number of different studies when people were in acute infection. And that's one thing we didn't talk about, but I would make sure, since she only had a rapid test in the emergency room, that she doesn't have acute HIV infection if we're thinking about PrEP. And as part of doing PrEP, we always look for documentation that someone doesn't have HIV, but we don't know that she hasn't been infected within the last 3 to 6 weeks. So I would just make sure about that too.
Yeah, and I think those are great points. And certainly, we referring or starting PrEP would not be done in a vacuum. Like, we certainly want to do that, but along with that, we want to address the other needs that she has. And I think sometimes, my concern is that we wait for sort of the perfect situation. It's like, well, once your substance use has been completely addressed, and you've been abstinent, and then that's the time when then we'll move on to this. And that's not necessarily the way things work for the patient. So she continues to be at risk. So addressing that risk, but addressing her needs, her homelessness, her continued use of drugs, providing then treatment, or at a minimum harm reduction, so that she has access to, so she can reduce that risk, is I think very important. But I think those are excellent points. These are, we need to not just focus on one thing, but really look at, what are her priorities, and then make sure that we're addressing all those needs.
Yeah, I think one of the challenges about PrEP is twofold, actually. One is that we sort of want to catch people when they're at their highest moment of risk, right? But as you said, that's when their life can be most chaotic. They're not necessarily ready to take a pill on a daily basis. And for women especially, that adherence becomes really important. They really need, up to 21 days of daily PrEP before they achieve a protective effect. So that can be really challenging while they're in the midst of their very high-risk activity. So the idea that PrEP becomes part of a package, of these other services, I think is important. It's not just throwing a pill at someone.
No, there is a balance, and again, PrEP would not be highest on my list. It's certainly if she came in and said, I heard that there's a pill that protects me against HIV, I'm really into it. Boy, I would be very excited about that, but I have a feeling that's not the case. She doesn't have a real medical home. Maybe by coming to you, maybe the ED, sending her to the infectious disease clinic or to a primary care clinic was the best thing they could have done. In addition to giving her antibiotics. And now that she does have a relationship, one thing that people who do PrEP a lot talk about is, a nice part about it is it does engage people in medical care. So if you're coming back to get your PrEP prescription every 3 months or so, that's an opportunity for the screening we've been talking about. We didn't talk about hepatitis C in her, but we'd want to certainly make sure we do everything we can to catch hepatitis C if she was, to detect it if she ends up catching it. Getting her clean needles, I think, in works is really, really important. Getting her hooked up with people doing that. There are some preliminary studies looking at co-locating preventive services with places like methadone clinics, and also other places where people who inject drugs go, including harm reduction spots. So I think syringe exchange programs. So I think we could be creative about that too, maybe with some community partnerships. But yeah, I would be really, have to say, you want to plant the seed in the right soil and nurture it and have it grow. And I just worry that of all the things, there's a lot else going on with her that I'm really concerned about. This is why I think if we have a daily pill is the problem. So what if we had something else that we can use instead? And I think it'd be interesting to talk to a whole bunch of people like her and just say, Rosie, like, if a daily pill isn't good, just so we know, what would be something that would be acceptable to you?
Yeah, and there's certainly emerging data on injectable cabotegravir and dapivirine vaginal rings and things, but not available yet. Really, the only thing out in the market is daily oral, and even for the idea of doing intermittent dosing, has really only been kind of proven out in men who have sex with men in the Outbreak trial. So really nothing with women yet, because we need that sort of higher levels of adherence.
Absolutely.
It's a challenge.
Yeah, no, I definitely think it's a challenge. One thing also is I'm wondering whether or not there's any ways, I'd like to explore more a little bit about her relationship with her partner. And is it a good relationship? Is it not so hot relationship? Is he supportive and loving or not? and maybe getting him in and getting him HIV tested, because if he was HIV positive and she just by the grace of whatever has not gotten infected, that might really motivate me as well to think about PrEP in her, because then I think the urgency goes up. And on the one hand, maybe many of her partners, other partners, are at risk for HIV, and some of them are HIV infected. So again, I think there's this balance here, but yeah, that would up the ante for me. And just finding out a little bit more about her partner and about maybe if he's HIV positive, because then I think it changes the calculus a little bit.
Yeah.
When you do know if he was positive.
Right, and presumably not engaged in care either.
Right.
So
Right.
that becomes
Right.
Yeah,
really
that's an
important.
excellent point. And I completely agree. I think we need to look at all the social determinants here that are that are playing an important role, and really try and address all the different needs. I think it's great that she showed up, right? That she
Yes.
got that referral from the emergency department, because as what usually happens is we have very high no-show rates at the point of referral. So and being able to provide support for the patient so that, and to engage them even before they show up for that visit, maybe an extra phone call, or now there are lots of different programs trying to offer support even before the patient shows up for that initial visit with a clinician, which I think it can help to then establish that relationship, and from there then being able to move on to provide the services that she needs. I think is good.
And maybe assessing what it is she hoped to get out of that visit, right? Like, well, what, after all these years of not being engaged in care and kind of living outside of kind of systems of care and support, what motivated you to actually follow through and come here today? So sort of establishing that relationship, so then we can build together a system that would work for her.
Yeah, and I think if she does connect, and I think that there is some interest in this, and I think the big thing we've all mentioned is at least let her know that PrEP exists, that this is an option for her. She knows about contraception options, she knows that she can go here for substance use treatment, she knows about AA or NA. Here's something else you should just know about. I don't want you to walk out the door not knowing it, even if you don't do it. If you do decide to do it, here's what it would look like.
Yes.
And I think we go through the steps, like we would test you for HIV, we would do it every 3 months just to make sure, because we don't want to give PrEP to someone who's HIV infected, right? We would check some very basic laboratories. It's not a lot of work. It's not a lot of burden on her. We get to see each other every 3 months, check in, doesn't have to be a big burden. We'll do STD testing, because it's really important, opportunity to check for that as well. And it could be kind of this hook that gets her in. The other thing that I would just add is, and that I think is really a thread through this, is also getting a sense of sort of what's her mental health history. And you mentioned it very clearly, there may be some self-medicating going on here, as there often is with substance use. Can again then we integrate PrEP with all the steps that we do according to guidelines with something that we can have her be invested in. Like, I want to treat your depression, I want to treat your anxiety, I know you're not sleeping well, tell me about antidepressants you've had before, maybe we'll start you on something at the same time or before, and then have it be a continuum where it's not just I'm going to my PrEP doctor, right? I'm going to my clinic because they're taking care of everything for me. And we could do your pap smears, and we could do your, so I think that co-locating of the services, but going through the steps, making sure she's a good candidate, continues to be a good candidate, and then as her risk changes, appropriately adjusting whether or not she needs to even be on PrEP anymore. And hopefully things change for the good where she may not be at risk. But it's very hard, and I prescribe PrEP, and I think we all are involved in it, and I have very few women who've really come in asking for it. And I think there's a lack of knowledge, there's a lack of appreciation for it, a lack of risk appreciation as well. So I think it's a huge challenge, really huge.
Importantly, though, I mean, we're all infectious disease specialists, who work on PrEP in part, but PrEP is so easy to prescribe. It's relatively well tolerated and safe and effective that if you do find people who might benefit from it, anyone can do it, right? You don't need a special, you don't need infectious disease board certification to.
Right, and there's so few people that really it's contraindicated for, other than being HIV infected, right? Even people with hepatitis B, we know can take it. You just have to be aware that if you're on TDF and FTC for hepatitis B, it suppresses hepatitis B. So now you're treating hepatitis B. So even if she said, I'm no longer having sex with anyone, or I'm having sex with an HIV negative person, I'm monogamous, she still would want to be on the medication to keep the hepatitis B suppressed. That's A. And B, there's very few people that have creatinine clearances that preclude them from, the vast majority of people walking on the street don't have a creatinine clearance less than 50. So I check a creatinine in these folks just for good measure for a few bucks. I don't need a Chem 68, but I try to just make sure that I understand they're a good candidate based upon the indication. And I think in her case that would be likely to be okay. So yeah, I would be interested to see how it works out.
Yeah, definitely. Well, hopefully for the better. Hopefully now that she's engaging in care.
Thanks a lot.
Yeah, thank you. Thanks.
Thank you for joining us. We hope you found this discussion informative. Next, let's summarize the key takeaways as SMART goals that you can implement in your practice. Evaluate patient priorities when considering PrEP initiation in high-risk patients. Develop strategies for integrating HIV prevention and substance use disorder treatment to promote adherence.